Welcome to AETCM, the emergency medicine channel. Shall we start? 50-year-old male patient came to our emergency with complaint of central chest pain, which was acute onset since 2 hours. So on arrival ER, initial 10-second assessment, patient was conscious and oriented. Coming to the primary survey, airway was patent. There is no pooling of secretions or gurgling. Coming to breathing part, saturation is 99% on room air, with respiratory rate is 18 and bilateral equal air entry. Coming to circulation part, BP was 150/90 with a heart rate of 90 heart beats per minute. Then disability GCS was full and pupils are bilaterally equally reacted to light, and exposure was temperature normal with GRBs of 160. During that time, the pain score is 10/10. So patient reached to ER with a complaint of acute onset of central chest, which was radiating to back. We taken a ECG to adjoin to a primary survey. We taken ECG. ECG showing there is no ST elevation or ST depressions. Normal sinus with Q waves on the chest leads. So for this pain score of 10/10, we given a analgesics injection paracetamol 1 gram IV stat was given initially. Then after some time pain was becomes from 10, it becomes 8/10, and because of severe pain of central chest pain, we send the cardiac enzyme also as an adjuvant. Then we take the BP of all 4 limbs. So in right side BP is 150/90.
Why you felt like taking BP of all 4 limbs?
Because of acute sharp central chest pain, we suspect aortic dissections or any aneurysm rupture. So to rule out that pain, we take the BP.
Okay. So, what was the type of pain he was complaining?
Pain is very sharp like pain, which was acute onset, which is ripping or shearing type of pain. So we check the BP of both upper limbs. Right side BP is 150/90.
So is it like a tearing pain between the scapula?
Between central chest and reaches spreading to interscapular region.
Okay, so always the pain won't be typically as if a patient is having a tearing type of pain in the interscapular region. Sometimes if it is an ascending aorta, aneurysm rupture and all, patient might have pain in front itself. Or if it is descending aorta only, patient might have pain in the posterior aspect. Okay, so BP was checked.
BP checked. The right upper limb BP was 150/90 and the left limb is 120/80. Okay. So there is more than 20 millimeter difference in systolic BP is there. So we suspected aortic dissection. So we done a USG echo in bedside. So it was showing on color Doppler suspect AR is there. So we give an expert cardiology consultation.
So what else will you check in the bedside echo?
In bedside echo, we can check for any ascending aorta intimal tear or intimal flap is there. Aortic because of this proximal tear, there causes annulus tear and causes aortic regurgitation. And also,
when will you be able to see the aortic regurgitation? In what view?
In parexternal view, we can.
Parexternal long axis
or in 4-chamber view, we can. Personal
long axis you will be seeing. Then we'll have to on the color Doppler. So when will you see the regurgitation? During systole or diastole?
Diastole. Along with that, we can see rule out any wall abnormality because of this tear, it will cause us decrease the blood supply to the coronary circulation, causes MI, and also we can see any effusion or the pericardial layers to rule out any cardiac tamponade. These all things we can rule out by bedside echo. So we suspect AR, we give a expert cardiology consultation.
So along with the echo, we will have to look for the arch of aorta. So we can look at above the sternum. You can just see for any dilatation of the aorta. Now, along with the plaques, we will have to check here also. Okay.
So expert cardiology consultation was given. Cardiology then echo. They advised like there is an intimal tear in the starting from the ascending aorta. Okay. So we diagnosed as a central chest pain with aortic dissection starting from the ascending aorta. So patient initial BP was 150/90 and heart rate is around 90. So our first management to control the pain by starting with the opioids. Pain still it's 8/10 and controlling the heart rate which is below the 60 heart.
That is management part. So with the adjuncts to primary survey itself, ECG was not. We took an ECG that was not showing any features of MI. Then you went for cardiac enzymes. Then bedside echo was done since patient was telling typical pain. That's why an echo was done and we were able to diagnose this. So otherwise we'll have to go. If the initial complaints itself is not much suggestive of this thing, we'll directly go to the sample history. So was there anything in the sample history?
Sample history: patient is known case of diabetic and hypertensive. Patient presented to ER with acute onset of chest pain, central chest pain, which was radiating to back since 2 hours. There is no history of syncope, loss of consciousness, sweating, palpitation, exertional dyspnea, or breathing difficulty. Then
So when we take the history, we will have to ask for the past medical, surgical history, then personal history and lots of the things. Why it is important in this case?
Past
Family
medical
history.
family history in high risk group is there. According to aortic dissection, there is high risk category. So, known case of hypertension, known case of any family aortic dissection or any aortic aneurysm, any past surgical history, any surgical manipulation of the aorta, cardiac surgery, any aneurysmal history, any connective tissue disorder like Marfan's, Ehlers-Danlos syndrome. Any antibiotic usage like fluoroquinolones, history of pregnancy, these histories we can.
Personal history for personal history. Smoking and cocaine and amphetamine use. We need to ask. So when we ask this history only, we'll be able to know what is the cause. So hypertension. So it can happen in 2 age groups. This aortic dissection. So either it can happen in young, that will be especially in case of any Marfan-Ehlers-Danlos syndrome and all, or in elderly because of smoking, long-standing hypertension like that. So, personal history you need to ask, or any recent surgical history like
aortic, any manipulation, or
aortic valve replacement surgery,
any bypass surgery, or any septal valve surgeries,
or any coarctation repair surgeries. Okay. Yeah.
These are the from high risk groups, and other coming to manage
head to foot
examination. Head to foot examination in aortic dissection we can check is like hypertension, features of hypertension because of cardiac, one is history of cardiac tamponade, or
that will be late change.
Otherwise is pulse deficits. Pulse deficit is the normally we will auscultate on the apex area. At that same time, we will palpate on the radial artery pulse. If there is deficits, simultaneously we will check. So after the every auscultation of heart sounds, then we get the radial pulse is normal. If there is any missing of the radial pulse, there is pulse deficit is there. So in aortic dissection, one clinical feature is pulse deficit. Other thing is cardiac tamponade features like muffled heart sounds, raised JVP, pulses paradoxes. Then next is pressure differences in arms, like more than 20 millimeter mercury systolic pressure difference in right or left arms. Then other features is like any focal neurological deficits.
Okay, so first we'll discuss about the cardiovascular system. So first thing you were talking about this pericardial effusion, if anything is there, you will hear the muffled heart sounds with tachycardia, that will be there. Then if the patient is having associated aortic regurgitation, you might be getting a mid-diastolic murmur will be there. And in that cases, we need to look for the peripheral signs of AR. In AR, when we check the BP, there will be a wide pulse pressure will be there. And then all the peripheral like Demoset signs,
splitting of heart sounds,
that should be checked. That is in the cardiovascular system. Then the chest, what will you see?
Chest, we can see the features of cardiac pulmonary edema features like bilateral crepes will be here because of the volume overload. Other than just
okay. Then coming to CNS. Why you are examining CNS?
CNS, ascending aorta route is involved. There is decrease the blood supply to the common carotid arteries, so will cause strokes. Other than that, if it is affecting the descending aorta, causing the intercostal arteries thrombosis or any decreased blood supply causes paraplegia.
Okay. Okay. And abdomen for?
mesenteric ischemia,
mesenteric ischemia, and
renal,
or
all
any
the
features
vital
of
organs.
abdominal aneurysm also. That also should be checked. So don't unnecessarily press on the patient's abdomen, but we'll have to screen for abdomen also. That is for staging. So how will you classify aneurysm, aortic aneurysm? Dissection.
Aortic dissection classification is two types of classification is there. One is Stanford classification, other is Debicki classification. Stanford classification is two types, type A and type B. Type A is involving the ascending aorta, arch of aorta, abdominal, thoracic aorta and abdominal aorta. Stanford type B is involving the descending aorta, which is distal to the left subclavian artery. Debicki, we can, three types are type 1, type 2 and type 3, type 3A and type 3B. Type 1A is, type 1 is involving the ascending aorta, arch of aorta and thoracoabdominal aorta. Type 2 is involving the ascending aorta only. Type 3 is involving the descending aorta, distal to the left subclavian artery, proximal to the celiac artery. Type 3B is involving descending aorta, distal to the left subclavian artery and distal to the celiac artery.
Okay, so what will you do to this patient? So in the abdomen examination, we will have to look for any visible, any pulses or anything seen or any features of aneurysm. So in the ER, how will you check for the abdominal aorta? Bedside ultrasound can be done. With keeping the probe facing towards the right side, you can screen below the liver, the aorta can be screened and you can trace it downwards. So any size more than 3 centimeter and all, we should suspect. Okay. So what was done for this patient?
In this patient, we initially given pain medication, then we controlled the heart rate and BP, which was 150.
So pain medication, what was given?
Opioids is the best drug, so we started on weak opioids like initially tramadol we started. Then pain is not relieving with weak opioid, we can start with fentanyl or morphine. So for BP control and heart rate is also in higher side. So better to start on beta blockers like just labetalol or esmolol. Labetalol dose we can give 10 to 20 mg IV bolus, repeat every 10 minutes. Then we can start on infusion of 2 mg per minute IV infusion. We can start of labetalol.
How will you start labetalol infusion?
We can take 3 ampules which containing 4 ml containing 20 mg in 1 ampule. We can take 3 ampule, then 24 ml per hour, it is 2 mg per minute is the dose.
Okay.
Then esmolol we can also start. Esmolol is like dose is 500 microgram per kg. IV bolus is the dose. We can start an infusion of 50 kg per minute IV infusion we can start. Maximum dose is 300 mcg per kg.
So what is the systolic BP target you are keeping?
100 to 120 is the target and heart rate is below 60.
Okay. Any contraindication for beta blockers in this case? Which all cases you will try not to
if the heart rate is less than 60, then we can start on vasodilators like nitroglycerin or nitroprusside.
Other than that?
Other than that, any patient with history of adrenal
You mean pheochromocytoma?
and that causing hypertension, we can start nitroglycerin.
No, not like that. No, labetalol will have both alpha and
action is
beta
there.
action. Not that. If the patient we are just diagnosing as thoracic aortic aneurysm and there is no features of rupture, and if the patient is having associated AR. So what happens in aortic regurgitation is the blood which is entering to the aorta is flowing back to the patient. So cardiac output will come down because everything is coming back to the heart. So how aortic aneurysm patients are compensating is with the tachycardia. So what happens during tachycardia? The diastolic filling will
Decreases.
come less and they will give more time for systolic. So in AR the blood will flow back to the heart during diastolic. So diastolic time will be reduced if there is tachycardia. So if you are unnecessarily giving beta blockers and reducing the heart rate too much, what will happen? The AR will worsen. So in that case, we will have to monitor and then only start beta blockers. Otherwise, we will have to plan on any AC inhibitors or ARBs. Okay, so if there is any rupture and all, definitely, and if the patient is going to get compromised, then in that condition we can start beta blockers and all. But otherwise, if the patient is stable, don't unnecessarily reduce the heart rate if the patient is having associated AR, if that is severe. Okay. So in AR patients also, another thing that needs to be monitored and given is this vasodilators and also Lasix and all. Also because AR patients are prone to have fluid overload and pulmonary edema. So in that case, we will be starting on NTG infusion, Lasix and all will be given. But what will happen is patients' peripheral vasodilatation will be happening. Already patients' cardiac output is low because of the regurgitation. So in that case, patients' circulatory volume will come down. Okay. Okay. So beta blockers, yeah.
Otherwise, if heart rate is already less than 60, we can start on vasodilators like nitroglycerin.
So if the patient is having associated abdominal aortic aneurysm problem also, how will you target the BP and heart rate?
Heart rate.
Okay, just imagine patient has only abdominal aortic dissection.
Less than 100 systolic BP.
Systolic BP you can allow up to 80. Systolic BP up to 80 we can allow, and a heart rate should be less than 80. BP and systolic BP and heart rate can be up to 80 you can allow the patient, because we can allow a permissive hypertension. Okay.
Other than that, we can go into investigation, like if a patient is hemodynamically stable, we can take the patient for CT aortogram. If unstable, better to do a tracheoesophageal echocardiogram. So in this patient, we control the BP, then taking the patient to CT aortogram. Then it is diagnosed as DeBakey type 1 aortic dissection. Okay.
What else can you see in a CT aortogram?
We can see where the flap is starting, where the any difference between the false and true lumen, and any hematoma formation, other vessels involvement.
Any thrombus or any associated pulmonary embolism, and also angiogram of the coronaries also can be seen. Okay. So this was DeBakey class 1. Type 1. Okay.
Another thing is we can risk score of aortic.
So how much centimeter was there this patient's? This was dissection.
Starting from ascending aorta reaching up to abdominal aorta.
Okay, suppose you are just seeing aneurysm only. Patient is having chest pain was there, but after giving your analgesics, pain everything subsided, and you did an angio and you just saw that patient is having just aneurysm. So what will you do? Depending on the size, how will you manage?
Aneurysm size, which is more than 5 cm, is definitive indication for surgical management. Other than we can observe every 6 months, we can observe for size. Like after 5 cm, taken for definitive surgery. So
if the patient is having a size more than 5, or a patient with a size less than 5 with some aortic involvement, then we'll have to plan on surgery, or we'll have to monitor every 6 months, and in the next 2 years, if the size is increasing more than 0.3, or if the patient size in the next 2 years, or in the next 1 year, if it is increasing more than 0.5 centimeter, then we'll have to plan on surgery. Okay. That is for aneurysm. Okay. So this patient what was done?
Aortic replacement surgery was done with aortic valve replacement was done.
Okay.
Aortic repair and valve replacement was done.
Okay. Then what happened?
Now patient is maintaining, not stabilized, on ventilator.
Okay. Anything else you want to add?
In aortic dissection, there is aortic dissection detection risk score is there. So it is divided into 3 categories. One is high risk category, clinical condition. Second one is high risk pain features, and third category is high risk examination findings. Category 1 is high risk clinical conditions. So patients non-case of Marfan syndrome, any aortic malfunctioning, any aortic valve disease, or any thoracic aortic aneurysm history. These are high risk clinical condition. That is category 1. For every condition, we give a score of 1. Then second category is high risk pain features. That is acute onset of pain with a ripping or tearing type of pain and severe pain intensity. Category 2. And category 3 is high risk examination findings. Examination findings, one is focal neural deficits, hypotension, pulse deficits, any diastolic murmur, and systolic BP more than 20 millimeter low. So for every category, every points give 1 point. Then which is more than 2 or equal to 2, then the patient is high risk category.
Okay.
Along with that, we can check the D-dimer. It is the new investigation, which was more than 500 nanogram, suggestive of aortic dissection.
Okay. Anything else?